Welcome to the UK Made Easy podcast, where we help aspiring international medical graduates like yourself achieve their dreams of passing their PLAB 2 and practicing medicine in the UK. Hello and welcome to yet another episode of the UK Made Easy podcast. My name is Steve, and in this episode I'm talking about optic neuritis, or it has been one of the subjects that has been commonly asked by many of PLAB 2 candidates. So I thought I'd do the heavy lifting in terms of reading and then kind of summarize the most important points you need to know for your PLAB 2 scenarios. In this episode I'm going to cover the types of optic neuritis, the presentation, the important questions to include in your differentials, the positive examination findings, and the importance of distinguishing certain types of optic neuritis. In addition to that, we're going to talk about management in terms of investigation and treatment, and of course we're going to end up with the prognosis. Along the way, I'm going to highlight certain information for you because they would be most probably to be brought up in a PLAB 2 scenario concerning optic neuritis. So to start off, we're going to talk about what optic neuritis is. And what it is that it's an inflammation of the optic nerve. Classically, there are three things that you need to remember when it comes to optic neuritis presentation. First thing is the reduced vision of varying severity. Second thing is the eye pain, particularly when it comes to movement. That's a very important point when it comes to PLAB 2 scenarios. The eye pain is exaggerated on eye movement. And then there is impairment of color vision. So the three things, the triad that you need to remember is that it is reduced vision, eye pain, especially with movement, in addition to impaired color vision. Now that we've done with what optic neuritis is, let's talk about the different types. The most important type that you need to consider is the acute demyelinating optic neuritis. This is the most common cause of optic neuritis in regions where multiple sclerosis is relatively common. And obviously we're talking about Caucasian populations and people of high altitudes. But at this point, it's very important to remember that acute demyelinating optic neuritis is closely related to people with multiple sclerosis or people who are prone to develop multiple sclerosis, as we'll get to see throughout our talk today. Now, we've talked about the first type. The second type is ischemic optic neuropathies, and that is giant cell arteritis, and that's very important. One of the things that I needed to highlight, because in your differential, when I say giant cell arteritis, you need to remember that you're going to include a question or two to exclude giant cell arteritis as a possible reason. Third type is corticosteroid responsive optic neuritis, and basically these are autoimmune diseases. Most notably will be the sarcoidosis, systemic lupus, and ulcerative colitis. So that's corticosteroid responsive optic neuritis. Fourth type is optic neuritis due to infections, and most notably is tuberculosis, syphilis, Lyme disease, periorbital infections, and the classic trio of measles, mumps, and rubella. So when it comes to infections, the most thing that would kind of stand out for me is the tuberculosis and the syphilis as well. There is also a nutritional cause of optic neuritis, and that is vitamin B12 deficiency, which gives you a clue that it might be a good idea to ask about the type of diet that they're following, that the patient is following. And the sixth type is drug-induced, and obviously what stands out for me from the long list is isoniazid, right? Again, we talked about tuberculosis, isoniazid, amiodarone, and ethambutol. So again, going really quickly over the types, we've got the acute demyelinating optic neuritis, again, commonly associated with multiple sclerosis, people of Caucasian nature, or high altitudes. And we've got the ischemic optic neuropathies, commonly associated with giant cell arteritis. We've got the corticosteroid responsive optic neuritis, again, with autoimmune diseases. Most notably, we talked about sarcoidosis, systemic lupus, and ulcerative colitis. We've got infectious reasons, most notably the tuberculosis, syphilis, Lyme disease, and the classic trio of measles, mumps, and rubella. We've got nutritional reasons, vitamin B12 deficiency, and we've got drug-induced, most notably the isoniazid, amiodarone, and ethambutol. Now that we've done with the types, let's talk about the presentation, the classic presentation that the patient is going to come up with. And we talked about three things that you needed to remember. The visual impairment, again, of varying severity. It develops usually in an acute or subacute manner over a period of hours or days, and may typically be exaggerating by a hot bath or a shower. And that's one thing that you need to remember. I'm going to park it over here now because we're going to touch upon this later on throughout the discussion. The fact that the visual impairment can be exaggerated by hot bath or shower. Second thing in the triad that we talked about is the pain around the eye, and typically it is worse on eye movement, something to remember again when it comes to PLAB 2 scenarios. And the third thing is the impaired color vision. Want to put your PLAB 2 knowledge in action and receive detailed feedback about your strengths and areas of improvement? Order the UK Made Easy mock service, where we don't only tell you how you did, but actually provide you with pointers on how you can improve fast. Head over to www.ukmadeeasy.net/book-online. That is www.ukmadeeasy.net/book-online. So some of the important questions to include into your differential is asking about light flashes. That's first. And the second thing, something called Othof's phenomenon. Now, I had trouble trying to pronounce that word, but it is pronounced Othof's phenomenon. And basically what it stands for is that increased symptoms, especially when it comes to visual impairment with raised body temperature. Remember when I said that I'm going to park the fact that it can be exaggerated by hot bath or shower, and hot environment or exercise are some of the things that could be associated with exaggeration of the symptoms, and that is called Othof's phenomenon. The third thing that I want you to remember when it comes to questions that are specific to optic neuritis is something called Pulfrich phenomenon, and basically it's an altered perception of direction of movement. So basically what happens is that there is asymmetrical conduction in optic nerves between one eye or another that leads to a curved trajectory, especially when it comes to seeing moving objects. So the patient is gonna talk about some disturbance when it comes to looking at moving objects. What we call that is Pulfrich phenomenon. So what you're gonna find on the examination is decreased pupillary light reaction in the affected eye, but you might also kind of be alert to the fact that it might be absent in bilateral cases. Most of the cases will be unilateral, but again, it might be bilateral, and in that case, you will not be able to distinguish the decreased pupillary light reaction. And then, of course, the positive examination also will include the varying degrees of vision reduction. We've already discussed that. And of course, the abnormal contrast, sensitivity, and color vision. Again, back to the same triad that we talked about. Things to remember is that it's very important to distinguish acute demyelinating optic neuritis from other types. And we've talked about 6 reasons or 6 other types that could be included into optic neuritis. And one of them has been acute demyelinating optic neuritis. And we talked about the fact that this is very important because it is closely related to multiple sclerosis in terms of it can develop to people who are suffering from multiple sclerosis, and multiple sclerosis can actually develop in people who had this type of optic neuritis. So the typical criteria or the typical findings in such patient would be the fact that it is an adult patient of 45 years of age or older. It's going to be unilateral reduction in vision. It's going to have an acute or subacute onset of visual loss, which progresses over 2 weeks, and then spontaneous improvement within 3 weeks. Pain that is worse on eye movement, but it does not disturb sleep. Again, something important to remember is that the eye pain, even though it is worse with movement, but it does not disturb sleep. And of course, patients with multiple sclerosis or recurrent attacks, this points you in the direction of acute demyelinating optic neuritis. Let's talk about the management now. In terms of the investigations, you're going to refer to an ophthalmologist for a full ophthalmological assessment, which typically includes visual acuity, contrast, and color vision, in addition to visual field testing, of course. And then there is a very good chance that they're going to do an MRI, especially if acute demyelinating optic neuritis is suspected, and they do MRI of the brain to give information about the likelihood of developing multiple sclerosis. And then the blood tests, which include full blood count, ESR, and autoantibodies as well, in addition to syphilis serology. Do not forget to include syphilis into your investigations. And then, of course, when it comes to imaging, in addition to the MRI, we do a chest X-ray, specifically if we suspect sarcoidosis, tuberculosis, or any sort of malignancy. There is some chance that lumbar puncture would be done because CSF need to be examined for immunoglobulins. Again, for optic neuritis of autoimmune nature, we test the CSF for immunoglobulins, oligoclonal bands, and infection. So again, let's quickly go through the investigations. We talked about the fact that we're going to refer to an ophthalmology assessment, full ophthalmological assessment. We're going to do an MRI in cases suspected where we are suspecting multiple sclerosis, because it can give us information about the likelihood of developing multiple sclerosis. And then we do the blood testing, which includes the blood count, of course, and then the ESR, inflammatory markers. We do the autoantibodies, and we do the syphilis serology. Again, when it comes to imaging, we do the chest X-ray to exclude sarcoidosis, tuberculosis, or malignancy, and there is a good chance that lumbar puncture would be done to examine CSF for immunoglobulins, oligoclonal bands, and infection. When it comes to the treatment, first line of treatment will be methylprednisolone. And the reason is it doesn't cure, again, just as much as corticosteroids do in almost all diseases where we use them at. They speed up the visual recovery in the acute phase, but they have no effect on the final visual acuity. So when you talk to the patient, you can say something like, it can speed up the recovery, but it does not affect how your vision will be restored. It has no effect on that. Okay, and it's very important to remember at this point that oral prednisolone is not recommended because of uncertain evidence that it might increase the recurrence rate. Something very important to remember, that we do not use oral prednisolone, we use methylprednisolone. And then we treat symptomatic. When it comes to symptomatic, we talked about Pulfrich phenomenon, which is the disturbed perception of movement. And this can be helped by using glasses with tinted lenses over the unaffected eye to balance the delay in the conduction from the other side. So we talked about Pulfrich phenomenon, the fact that the perception of movement is disturbed, and the reason for that is that because there is a conduction delay in the optic nerve of the affected eye. So what we do is that we make them use glasses with tinted lens over the unaffected eye to make up for the delay in the conduction. And the other phenomenon that we talked about is the Othof's phenomenon, and basically the fact that the vision acuity is worsened with raised body temperature. And for such phenomenon, we can do something like avoiding hot environments, taking cold drinks, reassuring the patient that this symptom is reversible and does not further damage the vision. So again, these are some of the self-help measures that you can roll out to the patient. Prognosis is very important to talk about, and the fact is 93% of patients do show improvement within 5 weeks of the onset of acute demyelinating optic neuritis. Vision continued to improve for up to 1 year. So there is a good prognosis, but there is high risk of recurrence, and that's very important to kind of touch upon to set expectations of the patients. Again, we talked about the fact that acute demyelinating optic neuritis is closely related to multiple sclerosis, and thus if there has been recurrence, right, there is a very good chance that they will be subjected to further investigations to check for the likelihood of multiple sclerosis. And we talked about the use of MRI for brain scans. I think that's pretty much covers everything that you need to know when it comes to PLAB 2 scenarios involving optic neuritis. Again, these are I kind of highlighted on the most important points that you need to remember: the triad of optic neuritis, how it is managed, right, and the phenomena that are related to optic neuritis. And we talked about the symptomatic treatment and the self-advice that you can roll out to the patient. Thank you very much for listening, and I'll see you in a future episode.